Hi, everyone, and welcome to today's webinar session. We're going to go ahead and get started. My name is Samantha Palmieri, and I'm on the marketing team here at Collective Health. I'll be taking the next few minutes to help us get started for today's session, and then I'll go ahead and hand it over to our speaker, Dr. Sanjay Basu. We appreciate you taking the time to join us given the circumstances with COVID-19. We hope we can provide some clarity today during these troubling times. Today we'll be focusing specifically on your COVID-19 questions, and we'll cover a range of topics related to testing, treatment, digital solutions, and dangers of misinformation in the public. We want this to be as collaborative as possible, so please don't be shy. We'll be answering questions after the opening portion of today's presentation, but feel free to submit your questions at any time. And last but not least, before I introduce us to our speaker, I'd like to point you to Collective COVID-19 online resource, which you can see the URL at the bottom left hand of the screen on the initial page right there. Thanks, Sanjay. This resource center features a risk assessment tool for folks concerned about symptoms, frequently asked questions, updated guidance for local and national authorities, as well as a variety of resources from some of our partners. We'll actually be updating this resource pretty regularly, so be sure to check it out. It's really helpful. And with that, I'd like to kick off today's session by introducing you to Dr. Sanjay Basu. Sanjay is actually our Director of Research and Population Health. He oversees Collective Health's efforts in understanding and improving the health of our members. Sanjay is also a primary care physician and epidemiologist and a faculty member of Harvard Medical School and Imperial College London.
Thank you very much, and welcome to the webinar. I'm going to try to address quite a few topics in a short period of time, but I look forward to your questions. I wanted to provide some updates on the latest developments from an epidemiologic perspective with regard to triage testing and treatment. I'll talk a little bit about chronic conditions as well that are not COVID and how we're trying to address those in the context of so much shift in the healthcare system and how we might better address those chronic conditions and what we're doing in order to help. I also want to talk about long-term planning. As we know, we're likely to experience a recession in this context, and how might we look at issues like plans regarding our cost sharing, regarding our trend, and what may we proactively ask in order to be prepared for that. And then we'll have some open Q&A. So let me begin from the beginning of the patient journey related to COVID. At the current point in time, there are increasingly reliable risk assessments to understand people's need to get further treatment for COVID rather than simply self-quarantining if one has symptoms. As you all know, triage for testing has been a dilemma due to the testing limitations we have here and around the world. And the bottom line is people with symptoms are being prioritized over asymptomatic folks for testing at the current time. However, there have been a lot of misunderstandings as well as dilemmas with regard to triaging people to testing. And so here's what we've done from the collective health perspective. In reviewing the literature and the up-to-the-minute sharing that's taking place within the medical field, it is pretty clear that the initial CDC guidelines were likely too narrow for symptomatic treatment. That is, while initial recommendations and actually technically current recommendations are still focused on fever, cough, and shortness of breath, there are actually quite a broader spectrum of symptoms that could require or arguably require testing and further treatment for COVID. And these are in particular are some of the diffuse flu-like symptoms, diffuse muscle pain, profound fatigue, and GI symptoms, which appear in about 10% of cases. Fever and cough appear in 50 to 75%. Shortness of breath actually does not appear as commonly, only about 30% of patients so far. So while fever, cough, and shortness of breath were widely distributed as the three initial symptoms to look for, a much broader set of symptoms and people with symptoms have actually ended up positive and requiring hospitalization for the disease. Our COVID risk assessment reflects that. In addition, the initial guidance and continued technical guidance is to preferentially screen people from certain countries that have had widespread coronavirus transmission. At this point in time, though, that seems a bit hypocritical because the country with the most widespread transmission is the United States. So we also reflect this in our guidance that many people who have not traveled abroad um, and are in communities that are heavily affected are themselves also likely to be exposed and may require further testing. Asymptomatic contacts right now, people who don't have any symptoms and simply live in an area where there's community transmission or have been in contact but still don't have symptoms, are currently not prioritized for testing per CDC guidelines. Yet we're trying to make testing as widely available as possible, and I'll talk about what Collective's doing in that context in a moment. Those folks who seem to be most adversely affected in terms of being most likely to not only be hospitalized but need intensive care and have progression to either acute respiratory distress syndrome, ARDS, which is the leading cause of death so far, or have potentially fatal complications of the disease, which are increasingly cardiovascular, which I can explain in a moment. Those folks are commonly with certain other diseases at the same time, particularly hypertension. There's some association with an antihypertensive drug in coronavirus, or a drug class rather. And not just older people, but also some younger people who particularly have heart disorders. And so I'll discuss that in further detail in a moment. With regard to testing, you're all undoubtedly familiar with the limitations currently being experienced with regard to testing. However, at Collective Health, we have found some strategies that appear to be working to enable our members to get testing. Here's what typically we have tried out and what we've found the most effective. When members call into our member advocates for testing, they're often first provided their plan information, as you know, under current legislation, the evaluation and management visits associated with getting a test, a laboratory requisition for coronavirus testing, as well as the test itself, currently come with no cost share. So for Collective Health members, as well as others, testing should be free from an out-of-pocket expenditure standpoint. That being said, the major limitations have been in finding a testing site that can accept you, as well as getting test results in a prompt manner and knowing what to do afterwards. We have tested out many of the databases available, found that one tends to be much more reliable than the other common two. The findcovidtesting.org website has been amongst the most reliable from our vantage point in screening with members. And this is a crowdsourced free initiative. The reason is that many of the other sites appear to list laboratories rather than just testing locations. And so people will show up to a Quest or LabCorp. Those are locations that will process the nasal or oral swab and do the physical laboratory testing to determine positivity. They do not, however, obtain the swab from you. If you're a patient and just walk in, they won't provide you with the test per se. They need to receive the swab from a provider's office. So there's been some misunderstanding and miscommunication, and many of the testing websites and testing maps out there falsely indicate that people can show up to those sites. We've contacted some of the larger ones in order to request revision of those false listings. The other thing we do is on our collective care team, if a person's over the phone and a collective health member, we do go ahead and call the testing site, confirm their hours, traffic, what kind of paperwork they need. A lot will require a laboratory requisition form from a provider or any other kind of laboratory order from a provider for COVID testing. That being said, a few, particularly county-based ones, will not, and that is a relatively new development. We confirm whether they're drive-through or in person. For immunocompromised people, for example, we have a preference towards drive-through. And we also confirm whether the person's already been tested for some of the other diseases, such as flu and RSV, respiratory syncytial virus. In about 20% of people in one limited cohort sample, people who were positive for COVID did still have one of those two other viruses. So it's not necessarily true, although it was initially suggested, that people who are positive for flu or RSV would necessarily be negative for COVID. There are co-infections occurring. And so after the testing, the other thing we make sure to do is ensure that the testing facility has the appropriate contact information for the member and their provider. What we have seen in some instances is pop-up drive-through testing where they're unable to provide the test result reliably back to the person and to their provider so that they can take appropriate next steps. The major limitations that we see right now at the testing sites are actually in the fiber swabs. There's limits on and shortages in the number of fiber swabs available. So we do confirm that at testing sites and redirect members as needed based on who has availability at the current time. It is incorrect that there are limitations currently to testing kits. There's no longer a testing kit. This was a misnomer because an initial set of kits were produced by the CDC, and that was a three-part testing process, and the third portion of the kit was faulty. However, the testing that's taking place right now, by and large, is either a particular type of molecular or antibody test, and this has not come in a kit form. And the reagents available for that are pretty widely available at the current time, at least as of this week. The other thing to know is some false claims that have been made in the testing space. For example, there's been some widespread advertising about at-home testing. Turns out these are not actually FDA approved. There were some false messages and press releases provided by some companies claiming they were, and those have been rescinded. At least as of this morning, there are not FDA approved at-home tests. The reason this matters is that it appears that the sensitivity of those at-home testing kits is very low. Even the existing testing that is FDA approved and available at legitimate sites still can miss almost a third, really just under 30% of positive cases. So people might be getting negative, but in fact actually have coronavirus about as much as 27% of the time. So that's already concerning enough. The home kits are even worse in terms of their positivity. And then maybe because people have trouble swabbing themselves, it's frankly an unpleasant experience to stick something up your nose and get a sample. And also because of the technology behind it and the preservation of the virus on the swab during transport. So at this point, we're not recommending at-home kits. We hope that one will be sufficiently FDA validated to be legitimate. However, there are legitimate antibody testing and molecular testing available that are more rapid than before. There was a false claim about a 2-day test, or a 2-hour test, excuse me, and that is also another false claim circulating. But there are tests that are within the same day, and we're looking particularly at some of the systems developed by Abbott and others that are built on top of a laboratory machinery that is very common and available at many labs. So we'll keep our clients up to date as this rolls out and as testing improves, but right now we're basically by hand helping members to obtain testing rapidly as possible in their area. We do have projections in place that also, if a person is positive and if unfortunately they're in the subset of people who need hospitalization, what we've been doing from our collective care team is helping direct them to centers of excellence, particularly for acute respiratory distress syndrome. So if they're symptomatic sufficiently and short of breath sufficiently or having other complications that could require a hospitalization, we're shepherding them preferentially to hospitals that have capacity and that have what's called an ARDSNet protocol. ARDSNet is a group of hospitals that are known as centers of excellence for the treatment of acute respiratory distress syndrome. They actually have a significantly lower mortality for treatment of that particular condition. We are in real-time monitoring the bed availability across the country of all hospitals, including ICU availability and ventilator availability, as well as their ARDSNet status, and we are redirecting members appropriately. The good news is on the West Coast, where I am right now, I'm lucky enough that the shelter in place provisionally appears to be improving in terms of flattening the curve. That may or may not change the total number of infections that take place, but it will spread those infections over a longer period such that health system capacity can address those people with serious conditions. As everyone here knows, of course, New York, New Orleans, now as of this morning, Dallas, Detroit, and LA are increasingly hard hit. And it does not appear that the surge capacity of those hospitals is sufficient. So we are actively transferring people across um, and making arrangements so that people with severe illness or in critical condition can obtain a ventilator. We will keep clients up to date as it affects their members. I'd like to talk a bit about the treatments available and how you might want to plan for coverage of these treatments, as well as what implications it might have for high-cost claimants, for surprise billing, and so on. So I have to give the proviso that, of course, none of this is intended to be personal medical advice. I'm giving this uh, webinar under the premise of being a physician as well as a research scientist in epidemiology. So I'll review the research literature. But of course, all of the lovely legal folks have advised me, and I will repeat that for personal medical advice, you of course need to talk with your individual physician. So with that important disclaimer out of the way, here's the latest in terms of the treatment available. Preliminary results, but not completed results, suggest the most effectiveness of an antiviral drug that was originally used to treat Ebola, and then MERS, Middle East Respiratory Syndrome, and SARS, all of which are caused by coronaviruses. And this treatment called remdesivir has a few different avenues for being obtained. It's currently available not only for severe disease, but also moderate disease among people who have been hospitalized predominantly. For the severe disease, there are also people who have been in the ICU and are intubated. They can't have had multi-organ failure or particular kinds of kidney failure. And also need to not be requiring pressors or drugs that maintain their blood pressure at a high level. So they can't have been too far along in their disease course within the ICU. But if they qualify, there are a few different options. One is through a series of clinical trials. Although there are 6 clinical trials worldwide, there's really only 3 that practically patients in the United States can get into. 2 are run by or administered by the drug company that produces remdesivir, Gilead. And those 2 are not placebo-controlled. They're comparing 2 different doses of remdesivir to each other in order to identify which one has least toxicity and most beneficial impact. The third trial, sponsored by the National Institutes of Health, does compare remdesivir to placebo, but is an adaptive trial, which means if people are doing poorly on the placebo, they can be converted over to the active group. And also the trial may be stopped early should they find that there's evidence of impact sufficiently to stop the trial and more widely distribute the medication. Outside of trials, it is possible to obtain emergency use or compassionate use for the drug among severely ill patients. For that provision, you do not have to be at a hospital that is participating in these trials. Naturally, there's a limited set of specialized centers that participate in those trials. We do call our members who are hospitalized, and particularly those who are in severe condition, and discuss with their families, ensure that they know about the availability of trials and that the providers also know about the availability of the emergency use provisions, and we have been assisting providers and families with entry into those trials. Secondly, there's been much more talk about hydroxychloroquine, known as Plaquenil. This is a more upsetting circumstance to those of us who are trying to practice evidence-based medicine. Essentially, a very poor set of studies was circulated on Twitter and social media rather than through a proper or respected peer-reviewed channel. And the studies were extremely poorly done. In the second case, there was no control group, so we don't know if people would have recovered anyway, which thankfully is the case for most coronavirus patients, or if it was the hydroxychloroquine that was leading them to recover. That the patients were also treated with a number of other agents, so we don't know if it was the hydroxychloroquine or something else that was leading them to improve. The improvement also was not actual clinical improvement or mortality. It was some surrogate marker of viral shedding, which is not actually a very good marker for disease improvement. Unfortunately, the authors decided that it was the best way of distributing the information they had been through social media. And so this has taken off as a suggested treatment, led to hoarding in some cases, some unprofessional behavior on the part of my profession of physicians, with some physicians hoarding hydroxychloroquine for themselves. I can understand the panic. Um, However, the data is quite poor at this point. People with moderate to severe disease are being prescribed hydroxychloroquine if they cannot get into a remdesivir trial or otherwise are unable to get the antiviral, but it is being prescribed on the basis of uh, almost complete uncertainty of its potential effectiveness in any legitimate study. The legitimate control trials to date preliminarily don't show much of anything. However, this is having the social media frenzy around this, and a lot of the misinformation has produced a problem for people who rely on the drug. So it is a demonstrated uh, a drug with demonstrated benefit for people with lupus, Sjogren's disease, um, and a number of other autoimmune conditions like rheumatoid arthritis. For those patients, the price bump and in some cases shortage caused by hoarding of this drug has led to people for whom it's definitely beneficial losing access to the drug, for people whom may or may not benefit at all. And certainly for people with mild coronavirus, the majority of people who are going to recover on their own, taking hydroxychloroquine is essentially a risk with unlikely benefit. It's not a drug free of side effects. In fact, one of the notable side effects that lupus patients and Sjogren's disease patients know is that they often have to go to an ophthalmologist routinely for eye exams. That's because the drug can cause blindness. So if you're going to recover already from coronavirus, induce yourself with blindness for taking a medication that's not indicated, it's a pretty perverse circumstance. Uh, there are other treatments that are currently showing promise. Convalescent plasma is one of those. Convalescent plasma is essentially taking a blood product from people who've recovered in order to transfuse into others the immune system reactants that can help fight the disease. Uh, the initial study, again, was very small, just 5 people in Wuhan, China, who recovered. They were also given antivirals. There was no control group. However, in this case, some replication studies have been taking place that suggest some promise. It's not a new therapy per se. This was already brought up in the context of SARS and other previous coronaviruses, but it takes a lot of coordination among blood centers in order to make this happen properly. There is a national coordinating group. So for people who can't get access to remdesivir, we are referring them into the coordinating group to be considered for the trial use of convalescent plasma or for compassionate use of convalescent plasma. So the bottom line for treatment right now is it's important to send people to centers of excellence for ARDS management. We're particularly keen on helping direct people right now to places that have capacity, particularly ventilator capacity, and are redirecting some folks from New York City and some smaller locations that have limited capacity at the moment in order to ensure that they can get the best care. What I would say is for plan administrators is to be very cognizant that among people who thankfully survive this, for that subset, the post-hospitalization care is likely to be extensive. Not only is ARDS and the ICU duration of stay likely to be quite long among some coronavirus folks, but a lot of the post-hospitalization chronic issues that develop due to the ICU admission itself, due to deconditioning and so on, are less familiar perhaps in the commercial population than in the Medicare population. This is not just limited to PTSD and mental health needs from the acute trauma of being in the ICU, but we often see extensive and long post-viral conditions, post-viral headaches, chronic migraines, post-viral pain, diffuse pain that's difficult to treat, and all of the chronic pain conditions that arise after ICU admissions. And so it's important to anticipate those in advance, not just the acute period in which someone might become a high-cost claimant or a high-risk member due to an ICU admission. The other thing we're working on a lot at Collective is the huge amount of non-COVID care that is pretty much all other healthcare prior to this that has either been canceled or delayed. Many people have used the term non-emergent to indicate what hospitals have canceled during this period. And many hospitals have canceled a number of surgeries, procedures, and other activities that occur within the hospitals. And clinics have closed down and generally chosen telemedicine options if they can. But that leaves a large amount of care that can't be administered through telemedicine and needs some sort of facility in order to provide. A common misperception is that non-emergent means elective, thinking of plastic surgeries or things like this. But at least among my patients and among collective health members, what we often see canceled are what other people would describe as quite urgent, just not COVID related. For example, people with brain tumors who need a removal. The surgery gets canceled, what do we do? People on chemotherapy, the infusions are canceled, what do we do? What we've been doing from a collective health perspective is rearranging and finding ways around the closures. We were doing initially this for cost reasons already with high cost drug infusions, moving them from hospitals to home, for example. But now that's taken an accelerated pace. For example, chemotherapies and other chronic infusions can many times be moved to home, but we have some dedicated pharmacists to do all the complicated arrangements, get all the authorizations in place, find a home RN that's qualified at the current time and that has the appropriate PPE and systems in place, get all the tubing, all the infusion pumps, and set people up for home care if possible, and also contact the providers initially, make sure they're appropriate and can be transitioned. I've been surprised at how many providers' offices have simply closed and either gone or not gone to telemedicine, and there's no plan for patients who have chronic needs, who either are just awaiting a surgery that's something you don't want to put off for months, like a tumor surgery, or chemotherapy or some other major issue, and there's not often a plan in place because everyone is so focused on COVID. With regard to the surgeries, what we've been able to do is arrange with ambulatory surgery centers that are off-site from the hospital, that have particular infection control procedures in place and still enable folks to be able to get that done, even if on a delayed basis, not as delayed as if they had to wait for hospital systems to fully reopen for those surgeries. Each individual hospital or ACO has often been widely varied in how they define uh, emergent and what they do or do not cancel. So calling between facilities within a given region can often help expedite those. And in particular, one thing that we can't move necessarily are, of course, labor and delivery events. Those are highly not in our control. And so what we have found is that different hospitals and different ACOs have safe protocols in place in order to allow for deliveries, but we have to manually arrange and help ensure that plans are in place prior to a woman going into labor. What unfortunately is the case in most hospitals is that a family member may not be allowed in the labor and delivery room with the person in order to reduce infection. I can't imagine what that's like, but just to prepare people for labor and delivery, it's important to know what a delivery might be like in a time of COVID, and it might be quite a bit more stressful, understandably, than during normal times where it's undoubtedly stressful enough. Thankfully, there does not appear to be robust data suggesting that pregnant women or newborns are disproportionately at risk despite their relative immunosuppression as compared to others for coronavirus infection, at least as of this time. In terms of moving on to some of the chronic conditions, one thing we're seeing in particular, and this is some research that we just published, is keeping track of transitioning from an acute period of response, emergency response to this circumstance, to preparing for the more chronic, longer term workforce challenges that we'll see. Absenteeism, this is in the case of healthcare worker absenteeism, but absenteeism broadly has been modeled by us as people in particular have challenges with childcare. We have a joke going around amongst those of us who are facing children with closed schools that instead of taking dependent care leave, we're hoping to take leave from dependents. That hasn't been initiated yet, but I'm hopeful at some point we could do that. Otherwise, absenteeism appears to be profound currently within the healthcare worker pool, even if people are not themselves sick because of limited childcare. And that's actually partly limiting the benefits of the school closures because you have less healthcare workers available. What we're doing is doing some dedicated modeling with our clients in order to see how they can respond and also how they might be able to address some of these issues in the context of ongoing layoffs, COBRA issues, FFCRA, and so on. And so I'll take this opportunity to move on to the questions now and address some of those more detailed issues as we go. So in terms of the questions, we have a list of 11 initial questions, and Tim and colleagues are going to populate more questions as the webinar continues. But I'll read out the question and then go ahead and answer them and also provide some resources online if that's of help. The first question we received is, do you have any thoughts on how I should think about the ways this will impact my overall claim spend over the next 12 to 24 months? Should I be asking my consultants certain questions or anticipating certain trends that I need to inform my finance teams about? Yes, so thank you for that question. So in terms of the impact on overall claim spend, here's what we anticipate seeing. From usual healthcare utilization, we do anticipate seeing at least a 5 to 7% decrement in total utilization from non-COVID related illnesses. In other words, just because of hospital closures, because clinics are closed, people with chronic diseases are getting less utilization of traditional healthcare entities. We do, however, see two countervailing phenomena. One is in terms of telemedicine visits. Of course, we're seeing a very substantial increase, on average, about 117% increase in telemedicine visits. And as you know, as part of the changes in regulations, we do have telemedicine covered in terms of cost sharing for COVID-related evaluations. But even for non-COVID related evaluations, we're seeing a bump in telemedicine. Now, because of the relative decrement in payment rates for telemedicine visits generally, those don't make up the full amount of cost for the decreased utilization. So we still see a decline in total initial trend in our projections. That being said, how much might you anticipate a cost trend increase due to coronavirus itself? There's a few factors in this. In terms of the incidence of people becoming high-cost claimants at the 50K per year threshold from coronavirus, the best projections we've seen are generally about 2 per 10,000. So if you scale that to your member population, you can anticipate how many high-cost claimants at that threshold based on current epidemiology, which of course may change. Within that context, the primary claim spend is generally not from the medications. So remdesivir, in terms of the antiviral rather, is not itself considered a high-cost drug. It hasn't provided an official commercial price because it's being distributed primarily through the trials. But in our claims data, we see generally less than $1,000 per treatment course. The primary expenditure is due to the ICU stay itself and due to extended need for ventilator support. So some of the people who unfortunately are affected very severely by coronavirus may need long-term ventilation, including long-term vent facility and a tracheostomy in order to provide long-term ventilation care. In addition, they'll probably need a lot of rehabilitation after an ICU stay, which involves a lot of deconditioning and pulmonary rehabilitation in that context. So that's where we see the hospital-based claims cost increasing. It's still unlikely from the best models we see to fully lead to a profound increase in trend because of the countervailing decrease in trend from usual care. That being said, those are projections over the next 6 to 8 months. And what we've seen previously from recessionary times is that people tend to decrease their utilization acutely from the recession itself, and then the claim spend rebounds profoundly between 8 and 16 months. So in planning ahead, one would anticipate that a lot of foregone needs may result in increased utilization and cost more in the 1-year period. And that would be things like cancer diagnoses that were delayed and therefore may be further along at the time of diagnosis, with all the negative implications of that. People who have delayed their surgeries, and now there's a backlog, a sudden spike in surgeries that were considered deferrable, and suddenly are done at a greater time period, or in a shorter time period, because they were deferred for so long. I would anticipate doing some detailed modeling with your consultant around how you can anticipate your reserves in that context, and with the finance team to anticipate a decrement followed by a bump in that context. So I'll move on to the second question, although please feel free to unmute yourselves and interrupt with additional questions or follow-up questions as I do so. The second question we received is, if my vendors are able to track COVID-19 related expenses or engagement, how is that information useful to me as a benefit leader? In essence, what am I not thinking about in terms of ways of using that data to drive some different strategy or implement a new program or engage my finance or leadership team? So tracking COVID related expenses or engagement, um, what I can do is talk about the kind of the three ways that um, this may have implications for you as a benefit leader. Um, First, what I would say is be very careful about um, using claims data for COVID test tracking. A majority of COVID tests are still being done by local, state, and federal testing labs, even though some private labs can do COVID testing, and that those appear on claims with the new testing codes, U001 and U002. Um, because a majority are still being done by government facilities, they do not appear in claims, and they're not billed, they're paid for out of government coffers. So the best way to track COVID-19 related expenses is not by looking for those HCPCS codes for the testing, but by looking for diagnostic evaluations. I have seen some COVID-related dashboards that have been distributed, and those I believe are actually underestimating the number of COVID-related evaluations because they're using just the new COVID code, the B79 code, or the U code for confirmed diagnosis. It's really important to also consider the rule out diagnoses, people being evaluated for COVID, but who didn't receive a diagnosis of COVID. And there's a list of other codes, and we can distribute those to you from the CDC, that shows the rule out cases, which will be a large number. What I would say is, because of the lack of cost sharing, there are of course plenty of people who are going to be evaluated for COVID, and as testing becomes more hopefully available, there will of course be a number of expenditures related to that. But what I would look for in particular is people who are actually admitted to the hospital, and whether the primary diagnosis is acute respiratory distress syndrome. That's a red flag for someone who is highly likely to need ICU, perhaps prolonged ICU admission. And if that's the principal diagnosis, rather than simply a vague pneumonia or bronchitis, that to us is a trigger to reach out to them, to help them with care navigation services, to talk to their family members immediately about how they're doing and what resources we can provide. That's also an immediate trigger for us to get permission to talk to the provider about remdesivir and other treatment options, about getting them to the Center of Excellence for ARDS management, and so on. In terms of strategies for programs, what I would say is people who have those types of diagnoses, particularly ARDS, it would be really important to let them understand their benefits in terms of the post-hospitalization, hoping that they make it out of the hospital, the post-hospitalization options for physical therapy and further recovery, as well as particularly for some of the behavioral health and mental health services that partner programs can provide. There is good evidence that on-site programs, so when people come back from work, on-site programs provided by the employer do not seem to provide as much benefit after a mass trauma or after uh, a massive change like this, for essentially collective PTSD. They don't seem to provide as much benefit as individualized therapy and CBT-based therapy. Um, And those I would recommend working with program partners in behavioral health spaces to provide what seems to be much more evidence-based care. With that, let me turn it back to Sam for a moment to talk a little bit more about how much time we have left, and then we can take some further questions.
Awesome. Thanks, Sanjay. Actually, yeah, we're running up against time now, but we do have quite a few questions. So we'll go ahead and run until noon. For those of you who have to jump off, again, we'll be sharing the recording. So don't worry if you're not able to sit through the entire session. Go ahead and Sanjay, take over and I'll close out once you're done.
Okay. So moving on to the next questions here. Number 3 question is, I've heard that this novel coronavirus is the great equalizer. Would you agree, or are there social determinants of health factors that I should be considering as a benefit leader that might suggest I need to do more or something different for certain populations, putting aside my payroll issues? So indeed, there's been a lot of public claims about mass pandemic like this being a great equalizer, but the emerging data don't necessarily agree with that, both from local health departments as well as from hospital-based registries. We do see disproportionate impact among certain groups, both of coronavirus itself, but also secondarily of some of the societal effects it's having. For coronavirus itself, we do see a disproportionate impact on those who live in congregate settings, who are marginally housed or homeless, but also among folks who are delaying care due to dependent care issues. So they're a care provider for the elderly, for instance, or of young children, and we see that they are presenting systematically later for testing and treatment under the premise of deferring their needs for others. And among the people who tend to be younger, less than 65, who rapidly progress to the ICU, we're disproportionately seeing that as a social determinant of health. The other thing that is particularly important in this time is that as people are facing employment uncertainty, we are seeing a lot more food insecurity and housing insecurity in the context of COVID. Not just because of COVID itself, but also because the response has led to people having to cut down hours, work reduced hours and reduced pay. And in that context, it appears to us that many people don't know about their resources available. These are people who are often not familiar with the safety net system. And so they may not know, for example, about the availability of SNAP in their area, the Supplemental Nutrition Assistance Program, or other assistance programs that are often supplementing those at the county or city level. And so I would say making those resources available has been a priority for us in the collective care team. We've definitely seen a spike in referrals to social services at this time, not just psychological services, but also material assistance, particularly for rent and particularly for food assistance. And these are among people who remain employed. The next question is somewhat related. In the event of layoffs, what do we know about COBRA? Is there anything we can do to extend and give our employees plenty of runway in their transition to a new health plan? So yes, in terms of the COBRA coverage, there's a few different options you have available. And I can distribute to you all a National Law Review article that's specific to COBRA coverage in the COVID era that I found helpful in terms of the flow chart for decision making. After you review your plan documents, if employees are required to work a minimum number of hours to stay benefits eligible and they don't meet those requirements due to a furlough, for example, they'll presumptively lose coverage, but you have two options as an employer. One is to not treat the furlough as a COBRA qualifying event and keep employees on the plan as if they were active. However, the medical insurance provider or stop loss provider may not agree with that waiver. And so it's important to check with them. They could also refuse to cover benefits for dependents in that context. The second is to treat the furlough as a COBRA qualifying event. And in this case, the COBRA coverage can be subsidized by the employer at your discretion. However, something to be careful about is that although, yes, employers can help pay for terminated or reduced hour employees' COBRA coverage, Such an arrangement could be considered discriminatory under IRS rules if the subsidy is not broadly offered. So it's pretty important to engage with your consultants and general counsel in the context of extending COBRA coverage in this setting. So the next question is, we want to help our employees as much as we can with costs for testing and treatment if needed, but not overexpose ourselves financially. Is there anything we should be considering with regard to stop loss? Yes. So with regard to stop loss, I think it's pretty important to talk with your stop loss provider about how they're tabulating the first dollar coverage in this setting, because um, testing and evaluation management associated with testing comes with no cost share for the member, but of course may have costs for you. Treatment is, however, currently has no cost sharing for the member in the context of mostly fully insured plans. For self-insured plans, it's at your discretion, the degree to which treatment will be covered. And this is also an area in which I do worry about surprise medical bills. When people, for example, are getting new therapies or experimental therapies, um, they can get surprise billing. And even if there's a compassionate use or emergency use provision, that often is still billed as an experimental therapy and so that otherwise not covered under their plan. And so you may need to do a plan exemption or some other provision for coverage, in this case for remdesivir or for some of the other treatments available. The only one that I am particularly concerned about with regard to cost is the convalescent plasma treatment. Um, Remdesivir is likely to still be under $1,000 a course. Plaquenil, hydroxychloroquine, and its associates are available at a much more moderate cost. The next question is, how would you characterize the spectrum of reactions from patients you've encountered from, I'm not going to change anything I do, to I'm hiding under the bed until it's all over? Fair enough. In terms of the spectrum of reactions from patients, I'd say most are quite anxious, understandably. There's a considerable amount of stress um, associated with people being aware that a recession is either upon us or coming at the same time as a pandemic that, by all appearances, is widely prevalent, circulating even among people who are asymptomatic, and pretty difficult to treat. I'd say now more than ever, the importance of behavioral health and mental health supports is apparent for us. I haven't seen too many patients who are not changing their behaviors in life. At least where I live, the shelter-in-place rule is being followed quite strictly, and we do see its benefits in the sense that at least within the Bay Area, as of yet, fingers crossed, we don't have hospital overload of the kind that has been seen in New York. The stretching or flattening of the curve does um, seem to be taking place. So I would say that I'm quite concerned about a long-term kind of collective PTSD that people are going to have from this. This is a highly unusual phenomenon and circumstance, and I would say queuing up and relying on behavioral health partners in this setting is now more important than ever. Next question. Telemedicine is getting more attention. How should we think about quality with this newish medium being used for members to assess care more conveniently? Is it easier to add services via our carrier or potentially some of the digital health solutions I'm reading about? So certainly, in terms of telemedicine quality, there are a few standardized metrics, and we can circulate those to you for evaluation. We do at Collective Health also have what we call our condition area reviews, where we evaluate our partners and look at the degree of evidence base for their medium and specifically for their platform. So for example, for our fertility partners, we look at singleton live births, NICU admissions, how many people get unexpected twins, are people using single embryo transfer? For behavioral health, we look at out-of-network mental health costs, what kind of drug spend is there, what degree of improvement is it on the standardized scales like PHQ-9 or G87. For telemedicine, there are also equivalents that look, for example, at the degree to which the telemedicine providers are able to successfully convert people who are not just self-selected into telemedicine, that is, they're not just purely new demand, but are actually people who are now able to manage their chronic conditions through the telemedicine platform. We also look at how well they are able to link to brick and mortar services when they're necessary. So this is a big part of what we're doing right now, is we're seeing telemedicine providers being variably successful in getting people to physical testing. Say I call a telemed provider and I'm concerned for coronavirus, and the provider's concerned, can they actually help me get the test, which of course can't be done through Zoom. So um, we're assisting those telemed providers to find testing, and they often have their own contracts. But one dilemma we're seeing is response time and variability in how well the testing center can actually accommodate the person, whether they're really truly well coordinated. And so we do communicate directly with the telemed providers and help them in that regard, as well as work with them in order to improve those functionalities. In general, others competing outside of the carrier space who are just directly contracted partners who we can integrate into our ecosystem for all the payments part, but still do warm transfers from our collective care team. We've just seen a different level of quality for members and for clients. That's my anecdotal experience. I'm not speaking for the company as a whole. In terms of the next question, I've been seeing a lot about the CARES Act, but not totally sure how it impacts our company. Any insights you can share here would be great. Sure, thank you for that question. So in terms of the CARES Act, let me first distinguish a bit the CARES Act, which is the Coronavirus Aid, Relief, and Economic Security Act, from the Families First Act, so Families First Coronavirus Response Act, FFCRA, which has more implications for the healthcare end of things. So the CARES Act has a number of provisions that you would classically think of as a stimulus bill. It has less implications for healthcare per se, but it does have a few. So there's some tax provisions for businesses. It allows you to get some loans for people, like student loans, refundable payroll tax credit, deferred payment on some of the employer share of Social Security tax, and also a temporary program to provide payment to those not traditionally eligible for unemployment benefits. Those are really all the major parts of the CARES Act. There are some provisions for healthcare, but those are mostly for hospitals and healthcare providers. It supports some telemed providers. It waives some billing requirements. It provides some additional funding to the CDC, and it provides some grants for geriatric care training. Now, that's kind of the limits of the CARES Act in terms of healthcare implications. The Families First Act, the FFCRA, has many more implications that I think is very much worth responding quickly to your employees about that one, and making sure you talk to general counsel and your consultants about it. In general, it provides that the covered employees, the covered employers have to provide to all employees 2 weeks of paid sick leave at the regular rate of pay when employees are unable to work due to quarantine or COVID symptoms or seeking a medical diagnosis. It provides 2 weeks of paid sick leave at 2/3 of the regular rate. If you're unable to work because you're caring for a family member due to COVID, or care for a child whose school or childcare site has been closed or is unavailable for COVID. And then employees that have been employed for at least 30 days can get up to an additional 10 weeks of paid extended FMLA at 2/3 their regular rate. So it's pretty important, I would say, to know about the FFCRA in addition to CARES when thinking about benefits policy right now. So the next question was, my health insurance vendor have care management models. How should I think about leveraging those programs during this time? What questions should I be asking them? Or strategies deployed should I expect to see from them that would benefit my employees who have underlying conditions or are potentially diagnosed? So I would say there's a few key things, and I'm happy to share our protocol for our care management model with you if that's useful. But there's several key things that I think would be important in this context of a care management model. The first is, are there specific provisions in place to help people obtain the test from the point at which they're experiencing symptoms? Are they actually checking if the testing site is a true testing site or not? Is it actually available? What paperwork will a member need in order to get the test done? How will the testing site contact the member after the test result, and what will proceed from there? And what is their turnaround time currently and their supply chain currently? The second is, if a person is sick enough that they need a hospital, how do they help members route to hospitals? Are they simply waiting for a person to actually go to the hospital themselves? Are they helping route them to a center of excellence? And what is the definition of center of excellence? Is it truly a place that has an ARDSNet protocol in place? Is it a place that is a clinical trial site from Decivir where a person might be able to access newer therapeutics? Is it a place that has an adequate blood banking system for convalescent plasma? Is it a place that has a dedicated pulmonary and critical care unit specialist, as well as an infectious disease specialist? What are the percentage of ICU beds available, and what are the percentage of ventilators available? Are all the ICU beds vent capable? Are the vents able to be buddied up? In other words, if vents do go in a shortage, does the hospital have a plan to be able to still be able to provide ventilation for someone who's ill? The third is, what do they do on discharge planning? Is it a simple discharge checklist, a kind of minimum amount? Or how do they coordinate in order to get the person to a high quality rehab facility? What is the rehab plan? And then next is, what are they doing in order to help not just members, but also clients understand at what point can people return to work? Right now, we're mostly under shelter in place guidelines, but after this point, what are the strict rules to end the shelter in place, even after a local municipality has entered the shelter in place? Do they have the key four provisions for determining when people can go back to work? Has the infection curve subsided sufficiently? What is the hospital capacity level locally? Have they arranged proper testing in place with the client so that they can test prior to medical release back to work? And do they also have enough provisions in order to provide chronic care during that time? And then finally, for the care management models, I would ask what they're doing to reroute people who have regular chronic conditions. How are they handling chemotherapy, surgeries that shouldn't be delayed? How are they handling specialist offices in particular who don't have telemed capacity, rerouting people or helping those offices set up? I think those are all pretty essential at this time. We're under extraordinary circumstances, so care management is pretty important to have as a very high quality threshold at the moment.
Thank you, Sanjay. I really appreciate it. Thanks again to everyone who joined us today. Just a friendly reminder, please check out that online resource center. We'll be hosting our next session, same time next week, with Lyra Health and Clio. We'll be continuing our discussion, diving into the impact of COVID-19 on the mental health of the public, and provide guidance on how to help employees cope with stress and anxiety brought on by the ongoing health crisis. So thanks again for joining, and we hope you have a great rest of the week. Thanks so much, and have a great day.